Morning everyone. I'm Dr.ANUSHA, Senior Resident Anesthesia Department. So today our topic is going to be on autonomic nervous system. Autonomic nervous system is a very wide topic. So for the MBBS level, you need to be very thorough with the basics, its classification, the receptors, the various receptors and its action, and the pharmacology about the autonomic nervous system. So what all receptors, what are the agonins, what are the antagonists acting at various receptors. So let's start with the basics of autonomic nervous system. So this is the classification of nervous system. So nervous system is classified as central and peripheral. Under central, we have the brain and the spinal cord. We are not going to cover this topic. Now, under the peripheral, we have two, the somatic and the autonomic nervous system. The somatic nervous system deals with everything which comes under voluntary control. So it is the skeletal muscles that constitutes the somatic. Under autonomic, we have all the involuntary actions. So whatever controls all these involuntary action will come under the autonomic. So the autonomic is further classified as parasympathetic and the sympathetic. Under parasympathetic, we have variety of receptors, like there are muscarinic receptors, there are nicotinic receptors. Parasympathetic means the cholinergic system. That means they release the acetylcholine. When you come to the sympathetic, it releases either epinephrine or norepinephrine. And this in turn also has various receptors. Broadly, it is classified as alpha beta, but under alpha we have further 2, under beta we have further 3 receptors. So have in mind the broader classification. We are going to deal with the autonomic nervous system proper alone. So this is that means sympathetic and parasympathetic. But before we go to the autonomic proper, first we will compare somatic autonomic, then we will compare parasympathetic sympathetic, then we will go into alpha beta. Okay. So this is a comparison of the first diagram somatic, 2 and 3 is sympathetic, 4 is parasympathetic. Somatic nervous system will have no ganglia. It is a single neuron pathway. That is, from the spinal cord to the effector organ, we have a single neuron, which is called a somatic motor neuron, which is obviously myelinated. So there won't be any relay in between. Directly, the acetylcholine will get released at the effector cell. Coming to the sympathetic, we have a 2 neuron pathway. Like in both sympathetic and parasympathetic, it is 2 neuron pathway. Somatic is always single neuron. Autonomic is 2 neuron. What are the 2 neurons? Preganglionic neuron, postganglionic neuron. So this itself says that there is a ganglion in between. So the second pic, this is the ganglia. This is the preganglionic neuron. This is the postganglionic neuron. Any ganglion you take, the preganglion will be myelinated, postganglion will be unmyelinated. Okay. So in sympathetic, the preganglionic neuron will be small. The postganglionic neuron will be long. In any nervous system, at the level of the ganglia, that there will be only release of acetylcholine. So it can be either a parasympathetic ganglia or a sympathetic ganglia. At the level of the ganglia, there will be release of acetylcholine only. Whereas at the effector cell only, there will be a difference. So if it is a norepinephrine or an epinephrine release at the post-ganglionic neuron, that is at the level of the effector cell, it is a somatic nervous system. Coming to the fourth pic, if there is a release of acetylcholine at the level of the effector cell, it is a parasympathetic nervous system. Here also there is a ganglion, but the difference is the preganglionic neuron will be long, postganglionic neuron will be small. It is acetylcholine which is released at both the sides. Now, there is an exception in the autonomic nervous system. Autonomic nervous system on the whole is a two neuron pathway. The only exception is the adrenal gland. So we have this preganglionic myelinated neuron that ends in the adrenal medulla. But instead of a postganglionic neuron originating and then releasing the epinephrine, this adrenal gland itself will release the epinephrine and norepinephrine. So this will have its action at various organ systems. So the only exception to the two neuron pathway will be the adrenal gland. The major things that you should grasp from this slide is for which the postganglionic neuron is long, for which it is small, which is the only exception to the two neuron pathway in the autonomic nervous system. Does somatic nervous system have a ganglia or not? So these are the major differences you should have in your mind before we move on to the next slide. So this is the same which are put into words. Somatic, what is the input? It will be mainly the senses, somatic sense, or it can be a special sense. In autonomic, it will be mainly the interoceptors which are the input. Where is the control of motor output situated? It is the cerebral cortex for the somatic. It is the hypothalamus for the involuntary control. That is the autonomic nervous system. As we already know, somatic is a one neuron. Autonomic, two neuron. Only exception, adrenal gland. What is the neurotransmitter released? In somatic, it is always acetylcholine. In autonomic, at the level of ganglia, it is always acetylcholine. At the level of the effector cell, if it's a sympathetic, it is adrenaline or noradrenaline. If it's a parasympathetic, it is going to be acetylcholine. So what are all the effectors? Somatic, it's obviously the skeletal muscle. In autonomic, it can be cardiac, it can be smooth muscle, it can be glands, it can be anything that is involuntary. So the response is always contraction of somatic, whereas it can be contraction or relaxation of muscle, it can be vasodilation or vasoconstriction in vessels, it can be an increased or a decreased secretion at the level of the glands. So the response in autonomic varies depending upon whether it's sympathetic or parasympathetic, depending upon which receptor it acts. So there is a wide variety of actions that the autonomic nervous system displays. Again, a few extra points are given, like only the conscious sensations are the somatic. The subconscious sensations also will come under the autonomic nervous system. There is no peripheral ganglia. Yes, there is a peripheral ganglia in autonomic. So we have now compared somatic autonomic. Now we are coming into the topic proper. We will deal only with the autonomic nervous system hereafter. It's a compilation of everything. It's a two neuron pathway. There is a preganglionic neuron. There is a ganglia. There is a postganglionic neuron. And the length varies between sympathetic and parasympathetic. So when you see the cranial nerves, the spinal nerves, everything all together, it is not that every nerve has a sympathetic and parasympathetic action. It's not like that. Certain nerves, they have only sympathetic action. Certain nerves, they have parasympathetic action. So the craniosacral nerves or the outflow will constitute the parasympathetic. The thoracolumbar outflow of nerves will constitute the sympathetic nervous system. Now, coming into the autonomic, under that, we are going to compare sympathetic and parasympathetic. So, the thoracolumbar T1 to L3 is the sympathetic outflow. Craniosacral, 4 pairs of cranial nerves, and S2 to S4 sacral outflow constitute the parasympathetic centers. We already know, I have already said you that the preganglionic neuron of a sympathetic nervous system will be small, which means its ganglia should be located very close to the spinal cord. So the ganglia position will be either paravertebral or prevertebral in sympathetic nervous system. Whereas coming to the parasympathetic, the ganglia is actually very close to the effector cell. Only then the preganglionic neuron will be long, the postganglionic neuron will be small. So it has to be close to the effector cell, which means its position is at the terminal point. So here, preganglionic, short in sympathetic, long in parasympathetic, and the ulta for postganglionic. And it does not always mean that there is a 1:1 ratio between the preganglionic and the postganglionic neuron. In sympathetic, for every preganglionic neuron, there will be many postganglionic neurons. Parasympathetic, for one preganglionic neuron, there is at least a few parasympathetic postganglionic neurons. So the sympathetic is actually distributed throughout the body. There is not a single portion where you can say that there is no sympathetic supply. So because the blood vessels are distributed throughout the body, so sympathetic will have its action throughout. Parasympathetic, it has only limitations. Like it's confined only to the head, thorax, pelvis, abdomen. That's all. You cannot see it in the upper limbs or lower limbs. Excuse me. So, what is the major action? It is the sympathetic has its major play in the fight or flight response. Parasympathetic, rest or digest phase, it will have its maximum response. Like its major role will be to conserve the energy. It will restore the body energy. Whereas sympathetic, it acts in an emergency situation, it will put forth its full action. Again, it is only a different representation of what we already saw in the second slide. This is the center, the CNS, preganglionic neuron, which is small, the ganglion. So it releases acetylcholine here. The postganglionic neuron is long, which means we are seeing the sympathetic nervous system. This is the effector cell where it releases norepinephrine or epinephrine. So the sympathetic is over. Coming to the parasympathetic, this is the center. Preganglionic neuron is long. This is the ganglia where it releases acetylcholine. Postganglionic neuron is small. At the effector cell also acetylcholine is released. So this is the somatic nervous system. There is no ganglia, one neuron pathway. Parasympathetic, preganglion is long, ganglia, acetylcholine at both the levels. Sympathetic, preganglion is small, acetylcholine and ganglia, norepinephrine or epinephrine at effector site. Exception to the 2 neuron is the adrenal gland, which is the 1 neuron pathway. Again, all these are different representations of the same concept. By repeatedly going through different diagrams, you can just make your points very clear. So your take-home messages should be at least the basic, the anatomy and the physiology at least should be very strong. So that's why I have given different representations of the same thing. Again, you can just observe this slide. You can yourself understand what are we trying to say. The first three is the sympathetic, the last one is the parasympathetic. Third diagram is the exception, adrenal gland. So whichever pick you are easy to understand, that you have in your mind, you keep it stored, so that whenever you are asked something about the autonomic, that pick should come to your mind, so that it will be very easy for us to gather at least 10 points based on a single pick. Actually, these nerve fibers, they have variety of classifications. The very important thing is the Erlanger's classification. So under Erlanger, we have it classified as 3, A, B, C. Under A, we have further classifications like alpha, beta, gamma, delta. So you can see epsilon. And how this is classified means it is based on the diameter of the nerve fiber and the velocity of conduction. So the diameter keeps decreasing as we move from A to C. And A and B are myelinated. C is unmyelinated. That is why the thickness keeps decreasing. That is, the diameter keeps decreasing. Whenever we have a myelin, the speed of conduction will be more. In unmyelinated, the speed will be less. So that is the concept between this conduction velocity. See, you can see the velocity keeps decreasing as we move from A to C because the myelination is getting lost as we move from A to C. And this B is the preganglionic neuron. Myelinated, visceral, preganglionic, autonomic is B. C is fully almost somatic, but when you see compared C, it has also action of like pain, conduction, all it is done. So mostly it's also somatic. So we already saw that at the effector cell, this epinephrine, norepinephrine, or acetylcholine, whatever, it's getting released. So how does this action take place? That is what is shown here. So you can see it is not that only when a stimulus is given, the neurotransmitter is synthesized. Not like that. The synthesis would have taken place already. There will be synthesis already done. There will be abundance in storage in vesicles. So when the stimulus comes, these vesicles are just released into the synaptic cleft. So that's all. It's not that only then the synthesis will start. It never occurs like that. So already the stored products are there. So whenever the stimulus comes via the postganglionic neuron, these vesicles are mobilized towards the end of the neurons. These vesicles are released via a calcium dependent channel. So there will be release of vesicles, there will be the opening of vesicles, the neurotransmitters are released. They will be pulled in the synaptic cleft and they will have its action finally in the effector organ. So this is the synaptic cleft, this is the effector cell. Synthesized, stored, mobilized, calcium-dependent release passes through the synaptic cleft, enters the effector cell. After entering the effector cell, it will show its action, whatever it is destined to do. It's just like a rhythmicity. There is always an afferent, efferent, sympathetic, parasympathetic, thoracolumbar, craniosacral, cholinergic and adrenergic, fight or flight, rest or digest. So it always comes in parts, just not a concept, just to know. So this is a slide that compiles everything about the autonomic into one. Its action on the whole, from the head to the toes. So on the left you can see the parasympathetic, on the right you can see the sympathetic nervous system action. So just have an example to make it more easy. If we know what are the actions of sympathetic, then it's very easy to just say the opposite for the parasympathetic nervous system. So like having that in mind, we will have an example. Like let's say tiger is chasing us. Tiger, so we do not often see a tiger. Let's see a dog, a stray dog is chasing us and we start running in fear. So we are having the fear that it will bite us. We have to run fast. We need a lot of energy to do the same. We have to run at our maximum speed. We should not get fatigued easily. And then we should reach our destination, be it like a home, and we should get locked up. We should get protected from the dog. That will be the main concept or the thought that comes to our mind when we are running in that stage. So let's have this scenario in mind. What all will happen in that particular phase, that all are the actions of the sympathetic nervous system, because that is the one that is involved in flight or fight response. So whenever you see a dog, and you should know that you have to run, your vision should be very clear. So your dilate, there will be a pupillary dilation. Whenever you are in fear, you are afraid of something, automatically your pupil will dilate. there won't be a saliva production that much. Actually, you will go dry, all dry. You will have a thirst. Even you will have like you need to drink water. Whenever you are running, your saliva won't be there. You will be a thirst response. So you will have palpitations. You will have sweating. Your BP will go high. Your both heart rate and BP will go high, which means there will be vasoconstriction. And whenever you are running, we need more amount of oxygen. So your bronchus will automatically dilate to allow more air to go inside the lungs. It will allow the air also to get exhaled. So bronchodilation. Then your muscles, that is you are running. So your skeletal muscles will need a lot of energy. It should not get fatigued easily. So what our body does, it will divert all the blood flow towards the skeletal muscles. So wherever it is necessary, it diverts. So where it is unnecessary, it is the GI mainly that is unnecessary at that particular time. So your GI blood supply will reduce, it gets diverted to the skeletal muscles. There will be a relaxation of the bladder. And for all these actions to take place, you should have energy, you should not get fatigued, the skeletal muscles should not go in for a cramp, it should not get tired. So for all these things, you need some abundance of glucose. So your glucose release will increase. And the overall thing for everything, for all these things to answer at the very first step itself, whenever you are afraid of something, so you are facing a flight or fight response, immediately the adrenaline is stimulated. Or like on the whole, to say your epinephrine or epinephrine release will be on the high. It will start to secrete a lot. And its action will be the whatever we discussed before. Whatever is on the right side is everything the action of the adrenaline and the noradrenaline. So you can see it is just the opposite for the parasympathetic nervous system. It is the rest or the digest response. So for digestion to occur, we need a lot of saliva. We need a lot of blood supply to the GI. We do not need for the skeletal because we are resting. So the ulta occurs. In resting, we need not have much amount of oxygen, the bronchoconstriction. In rest, we will not have hypertension or tachy. So there will be only a brady phase, or there will be a normal heart rate and a normal blood pressure. So it will have a decreased blood pressure, decreased heart rate. And it will contract the bladder. So in a rest or digest response, we will have a urinary frequency. We will have a urge to urinate because there will be contraction of the bladder. So what we saw in the previous slide was a comparison between sympathetic and parasympathetic. What we are going to see in this slide is a comparison of the sympathetic alone, which means we are going to compare the receptor alpha and beta. Both comes under sympathetic only. So you see here, in the eye, whenever the alpha is stimulated, there will be contraction of the radial muscles. There will be mydriasis. Whenever beta is stimulated, the ciliary muscles will contract. Glands, only alpha action, secretion will increase. Heart, there is only beta 1 action. Not only the heart rate goes up, the speed of conduction, the contractility of the musculature, everything will increase. Overall, the cardiac output will increase, there will be heart rate increase, there will be a BP increase, increased risk for arrhythmias. Lungs, actually, there are different actions. So, not that in every sympathetic stimulus, there will be a bronchodilation. It's not the same. Whenever there is an alpha action, bronchoconstriction, beta action, bronchodilation. So that is why we are using salbutamol. Salbutamol is a beta agonist. It's a beta 2 agonist. So when do we use salbutamol? In any acute exacerbation, asthma, COPD, bronchospasm. So all those conditions we use a bronchodilator. So bronchodilator is a beta 2 action. Coming to the important concepts like bladder. Bladder, alpha will always act at the sphincter level, beta will act at the muscle level. That is smooth muscles action, more of beta 2 action. So, and this is very important. Abdominal blood vessels. Alpha is always vasoconstriction. Beta is always vasodilation. So, whenever you go for an alpha to agonist, you will have a vasoconstriction property only. So, this is a pictorial representation, like fight or flight response. This is adrenals. What is it? It is the only exception to the two neuron pathway. So, that is the adrenaline or adrenaline are directly released from the adrenal. So it has only a preganglionic neuron. And nearly 80% of the release will be epinephrine. Only 20% or around only will be noradrenaline. So, like we have a variety of, not variety, there are a number of craniosacral, there are a number of nerves, cranial nerves, spinal nerves, there are many. And they all relay in a ganglia. So it is a slide that shows how many ganglia are there present at each level. So in the cervical region there are 3. Thoracic is either 11 or 12. Lumbar and sacral there are 4. The coccyx we have it named as ganglion impulse. The ganglion itself is named as. Cervical ganglia also has names like the compilation of C1 to C4 is superior, C5 and C6 alone is middle, C7 and C8 nerves lay in the inferior cervical ganglia. Actually, the preganglionic fibers will come out of the spinal cord, or it can be the cranial nerves where it comes out of the brainstem. So sometimes they directly relay in the same level ganglia. Sometimes it can ascend or descend for a few levels. Then it can relay in that particular level ganglia. Or it can pass even without a synapse to a prevertebral ganglia. Like it can be either the paravertebral ganglia or a prevertebral ganglia that is used for the relaying purpose. So we know that T1 to L2, that is the thoracolumbar outflow, is sympathetic. So the sympathetic outflow, the nerves come out, they relay in the prevertebral or paravertebral ganglia, then they will have the postganglionic neuron. They will finally end in an effector organ. So what are all the effector organs that are covered with the thoracolumbar outflow? T1 to T5 covers the head and neck, the upper limb, the thoracic viscera. T5 to T12 abdominal viscera. L1 to L3 pelvic viscera and the lower limbs. So you can see that the sympathetic nervous system covers the entire body. It's not like the parasympathetic, which covers only the head and neck, thorax, abdomen and pelvic. So it will never cover the upper limb or the lower limb. So just a pictorial representation of the same concepts that we know. So the same thing, T1 to L2 segments, there are 14 pairs of ramus. Relays in the prevertebral or paravertebral ganglia. Coming to the parasympathetic, it is either the rest or the digest phase. So the cranial nerves, what are all the parasympathetic cranial nerves? We have 4. You must have all read in your anatomy first year. You must have forgotten. Right. So there are 4 cranial nerves, 3, 7, 9, 10. All these 4, they come under the parasympathetic pathway, that is the parasympathetic control, all these things. Of course, cranial nerve 10 is the most important of all, the vagus nerve. The leader of or the head of all the parasympathetics is the vagus. And it has a very longest force. Vagus itself, it means it is actually derived from a term which is its meaning, or in meaning its real aspect is wanderer. The word vagus means wanderer. So it has the longest course of anything in the body. So anywhere if you open right from the head, neck, thorax or abdomen, you can always see a vagus and its side effects. So apart from the cranial outflow, there is the sacral outflow. So sacral outflow mainly S2, S3, S4 alone constitutes the parasympathetic outflow. So it can be either a cranial parasympathetic or a sacral parasympathetic. The pathway is almost the same, only that the origin, it is either the brainstem in a cranial or a sacral spinal cord in the sacral outflow. Other than that, there will not be much of a difference in the anatomy aspect. Like preganglionic neuron is always long, the postganglionic neuron is always small. The ganglion is at the terminal region. The effector organ, as well as in the ganglion, there will be release of acetylcholine only. So in all such aspects, there is no difference. Where the origination occurs, brainstem or the sacral spinal cord. So we have seen almost everything about the anatomy. So what is the major physiology? Like, not to say this is the full physiology. The major physiology, everything almost like covered cardiovascular function is covered in this slide. So let's take like whenever the mean arterial pressure is low, the baroreceptor will get stimulated. What does this do? It will stimulate the vasomotor center. So the VMC in turn will stimulate the sympathetic nervous system and it will inhibit the parasympathetic nervous system. So this sympathetic nervous system will stimulate or it will increase the venous tone. It will increase the contractile force of the heart. It will increase the heart rate. It will increase the peripheral vascular resistance. Whenever the venous tone is increased, venous return increase. So the heart contractility increases, stroke volume increases. Heart rate increase, then cardiac output will increase. Because cardiac output is a multiplication of this heart rate and stroke volume. When the stroke volume and heart rate increase, cardiac output will increase. When the peripheral vascular resistance increase, it directly means the mean arterial pressure is at an increasing trend. So all these factors will increase the mean arterial pressure. This is one pathway, that is baroreceptor pathway or autonomic feedback loop. There is also a hormonal feedback loop, that is the renin-angiotensin-aldosterone pathway. That means whenever our body is facing hypotension, the blood flow will be reduced to all the organs. So similarly, the renal blood flow will also decrease. But there will be sensors in the renal afferent blood vessels. What does this sensor do? It will release renin. That renin will further in its pathway of mechanism, it will get converted, will get angiotensin, then angiotensin 2 will form, then the final product aldosterone. What does the aldosterone do? It will retain sodium, it will eliminate potassium. So by all these mechanisms, it helps in increasing the blood volume. So whenever the blood volume is more, the venous return is more. Whenever the preload is more, the afterload is more, that is stroke volume. Whenever the stroke volume is high, it means the cardiac output is high, and thus the mean arterial pressure is high. It's a very beautiful picture, which says the physiology of how we can say like how the homeostasis of blood pressure is maintained. Excellent diagram, very nice. So now the receptors. We have now learned the wide classification of autonomic. We compared the somatic autonomic. We compared parasympathetic and sympathetic. Now we are coming to the last stage, the receptors. So parasympathetic, we have muscarinic and nicotinic receptors. Muscarinic, we have M1 till M4. In nicotinic, we have N1 and NM receptors. Under sympathetic, we have alpha and beta receptor. So in alpha, we have alpha 1, alpha 2. In beta, we have beta 1, beta 2, and beta 3 receptor. So the major receptors alone, you should just have in your mind. Like M1 and M2 will be major action will be at the smooth muscles. And in beta 2 major action will be the smooth muscle. Beta 1 major action will be the heart. Alpha 1 will be smooth muscles. And beta 3 is not of much use. It only has its action in the lipocytes. Nicotinic NM will be mostly the neuromuscular junction, and N will have major role in the nerves only, nerve endings, nerves only. So on the myocardium is M2. M2 is for myocardium, beta 1 is for myocardium. This is just how it has its action via the adenyl cyclase pathway or phospholipase pathway. So those concepts. Now we saw the list of receptors. Now alpha alone we are comparing. What is the difference between alpha 1 alpha 2? Actually, much of the action is the same. Alpha 1 major action is at the smooth muscles. So alpha 1 only will have major more actions. Alpha 2 they have only limited actions. The major difference between alpha 1 and alpha 2 will be its action in the blood vessels. Alpha 1 will cause vasoconstriction, alpha 2 will cause vasodilation. How does this vasodilation occurs? Because it will have a inhibitory action in the central sympathetic outflow. So in the brainstem, this alpha 2 receptor will inhibit the sympathetic outflow. So since this outflow is low, there will be vasodilation. So since the outflow is low, there will be decreased release of adrenergic and cholinergic, that is neurotransmitters. So all these will get decreased. And alpha 1 only will have many actions because it innervates the smooth muscles. So there will be bronchoconstriction, vasoconstriction, GIT, there will be relaxation. But sphincter will contract. Muscles will relax, but the sphincter contracts, uterus will contract, the bladder sphincter contracts. So all these are actions of alpha 1. So alpha 1, blood vessel constriction, eyes mydriasis, bladder relaxation. So alpha 2, blood vessels will dilate, BP will fall, smooth muscles, similarly there will be a decreased tone and motility. So GI action will be the same for alpha 1 and alpha 2. Coming to the beta action, beta 1 heart, it will increase the heart rate, speed of conduction, the contractile force, so everything will increase. Kidney, there will be increased renin, thereby an increase in BP. Coming to beta 2, the more of smooth muscle action is from beta 2. So GI, there will be decreased tone and mobility. So GI action will be the same for alpha, beta, everything, there will be the same. Lungs, there will be bronchodilation. Uterus, there will be relaxation. Liver, there is an increased blood sugar release if the beta 2 receptor is stimulated. So this is, now we have seen a lot about anatomy, a few things about physiology. Now the biochemistry. So what is the biochemistry? Where it is starting? Where is all these reactions starting from? It is from tyrosine. So from tyrosine we have the dopa form, then the dopamine forms, then the norepinephrine forms, finally only the adrenaline forms. So your first year subjects, everything now we have completed. We have seen the anatomy, the physiology, the biochemistry of the autonomic nervous system. Now we are coming to the second year, third year topics, the pharmacology. First year subject is over. So this slide shows us a collection of the sympathomimetics. Sympathomimetics means their actions will be similar to the sympathetic nervous system. So there are catecholamines like epinephrine, norepinephrine, dopamine, dobutamine. All these are natural. We have synthetics, like we have ephedrine, mephentermine, phenylephrine. So all these are non-catecholamines, but they are also sympathomimetics. But means they also have actions sympathetic, like sympathetic nervous system. They either stimulate the release of alpha beta or they have their actions at alpha beta levels. Okay, so regarding anesthesia, we actually use a lot of, and it's a very common also, ephedrine, phenylephrine, ephedrine. These are common drugs which we are using for treating hypotension. Hypotension is a very common event we face during regional anesthesia. It is spinal, epidural. So there all these drugs play a very important role. This single tabulation, it just says a compilation of all the catecholamines, which means like where all it will act. So just with the knowledge about where it acts, we can just say what will be the response. Whenever the alpha action is present, vessels, vasoconstriction will be there. Whenever there is a beta action, its action on the heart will be there. So just know alpha means blood vessel, beta means heart. So now we are going. Epinephrine, beta action will be more than alpha. So heart, cardiac output, heart rate, arrhythmia risk, all these are high with epinephrine. Since alpha action is less, we cannot expect much of a peripheral vascular resistance raise or an MAP raise with the epinephrine. So its major action is at the heart level. It is the only drug used in CPR. So norepinephrine, coming to norepinephrine, its alpha action is more than beta. So it's a major vasoconstrictor. It's a major factor. Like whenever you are using the mean arterial pressure rise with norepinephrine is the maximum compared with any other drug. Since the beta action is not that much, we cannot expect, we need not worry about a heart rate increase or an arrhythmia risk with the norepinephrine usage. Dopamine will have its action mainly in a smaller dose, it will have its action in dopamine D1 receptor. Then it will have the alpha action, and then it will have alpha beta actions with the increasing dosage. Coming to dobutamine, it acts only on beta 1. So beta 1 action on the heart. So heart rate will increase, the contractility, the speed of conduction. So there is also an arrhythmia risk with dobutamine. Coming to ephedrine, it has only, it is not only, like it has more of an alpha action than beta. So vasoconstriction, mean arterial pressure rise, peripheral vascular resistance, all these increases with ephedrine. But since there is also a beta action with ephedrine, we should also be aware that it will lead on to tachy and arrhythmia risk is also high with ephedrine. But phenylephrine, it has only alpha action. So it will only lead to an increase in BP. And actually, its side effect also includes brady. Since there's no beta action, it's not like its heart rate is maintained, but there is also a risk of brady with the phenylephrine. So its dosage should be very safe and titrated one. So just keep in mind, epinephrine beta more than alpha, norepinephrine alpha more than beta, dobutamine beta 1, phenylephrine only alpha, ephedrine alpha more than beta. So just have what receptor action is maximum. So if you know what receptor the drug acts, then you can very well come to what are the action it does. So just remember the receptors alone. Same thing put in another way. So phenylephrine, there will be a brady effect. But the maximum rise in mean arterial pressure is with norepinephrine and phenylephrine because its alpha action is more. The maximum rise in heart rate will be from dopamine and isoprotronol. And this last column is about the renal blood flow. You can see the renal blood flow actually falls with every drug except dopamine. Dopamine is the only drug that increases the renal blood flow. So dopamine is a renal protective agent. So whenever you are facing a patient with hypotension, and also that the patient is in renal failure or in a renal injury, there is a risk of renal injury or anything like that, you can always go in for dopamine. So yeah. So this tabulation gives the pharmacology. Alpha 1 agonist, phenylephrine. Alpha 2 agonist, clonidine and dexmed. Beta 1 agonist, dobutamine. Beta 2 agonist, terbutaline. Beta 2 agonists are bronchodilators. So these are all used in asthma, COPD. There are many drugs coming under bronchodilators, even salbutamol, salmeterol, formoterol, and whatever is listed here, albuterol, terbutaline, everything are bronchodilators only. Just the duration of action will differ among the drugs. They can be taken either in oral, subcutaneous, or inhalation. So there are wide variety forms for the same. Now, so this is just the classification. So this is beta blockers. There are many beta blockers. We commonly know beta metoprolol, esmolol, levetolol, acebutolol, betoxolol, carvedilol, atenolol, misoprolol, sopropranolol. So there are many beta blockers. So why do we use beta blocker? We normally prescribe beta blockers for hypertension. But apart from hypertension, there are many indications for using beta blocker inhibition. We can manage angina, acute coronary syndrome. Why? Because the heart rate decreases, the demand by the heart decreases. So whenever the demand decreases, it means the oxygen supply demand ratio will be in a balance. So the heart is not much prone for IMI or further ischemia. So management of angina and acute coronary syndrome. Perioperatively, in pheochromocytoma cases and hyperthyroid patients, whenever we need to suppress the sympathetic nervous system activity, we just give or prescribe beta blockers in the perioperative period. It's also an antiarrhythmic. Even in congestive heart failure management, we use beta blockers. So intra-MI treatment also, like prevention aspect also we can use. Like people who are on long-term beta blocker, they always have a cardioprotective effect. So why does this cardioprotective effect occurs means there is a decreased myocardial oxygen consumption and demand. So since the demand is less, there won't be much strain on the myocardium. Its blood flow is also increased. Why? Because there is vasodilation, because there is redistribution from the non-ischemic to ischemic areas, and the catecholamines are attenuated. It has antiarrhythmic effect, anti-inflammatory effect, and the block is also stabilized. So overall, the beta blocker, they have much of a cardioprotective action. So apart from beta blockers, we have calcium channel blockers that are also antihypertensives. So actually, among this, dihydropyridines, they won't have action on the SA node or AV node. Whereas verapamil and diltiazem, they have action on the SA node and AV node. They actually they cause a depression. So whenever you use verapamil or diltiazem, there will be a mild decrease in heart rate. That is not true with dihydropyridines. So the sympathetic system pharmacology is like only the outline is over. You have already read in detail about all this pharmacology in your MBBS. So coming to the parasympathetic, there are direct parasympathomimetics and there are indirect. Direct acetylcholine, methacholine, retinol, so all these things. And indirect means like we are either inhibiting the acetylcholine esterase or like indirectly we are inhibiting the destruction of the acetylcholine. So reversible comes the physiophytostigma newstigmin, and being an anesthesiologist, this newstigmin is a very commonly used drug. We use it for reversal agent. That is for reversing the patient out of the neuromuscular blockade. We use in general anesthesia at the end of surgery. Irreversible, they mostly constitute the OPC poisons. So since adrenaline, we know beta action is more, which means the heart action is majority at the heart. And heart, whenever the action is at the level of the heart, the systolic BP will be high. Whenever the action is at the level of the blood vessel, the diastolic BP will be high. So in adrenaline, since the beta action is more, the systolic will obviously rise, but diastolic will fall. So there will be a wide pulse pressure in such patients. Since the beta action is there, the heart rate will also increase. Whereas when you consider noradrenaline, alpha action is more than beta. So since alpha action is there, the peripheral resistance will increase. That means the diastolic will increase. But in this, systolic blood pressure and diastolic both simultaneously will increase. So the pulse pressure will not be that wide as you can expect in adrenaline. And there will be heart rate either maintained or there will be a fall in the heart rate. Beta will increase the force of myocardial contraction, the rate of contraction, and there is also risk of arrhythmia because the speed of contraction is also increased. Beta 2, we know it's a bronchodilator action. Actually, these are all slides that are related with anesthesia and autonomic nervous system, so you need not know much about that. So, coming to, can there be a condition called ANS failure? Definite yes. So, what are the signs? Patient will be having orthostatic hypotension. There will be a resting tachycardia. Even at rest, patient will have tachycardia. There will be anhidrosis. GI, patient will experience, it can be either constipation or diarrhea. Urinary frequency will go high. And there will be a reproductive failure. Ejaculation failure, erectile dysfunction will be there in males. So there are many tests to detect if the anus is going in for failure or not. So one such is the Valsalva maneuver. Next thing will be to test the orthostatic hypotension. BP can be recorded. BP and heart rate can be recorded in supine position and standing position. So you should just know that there are concepts of ANS failure. So just a compilation of what all we have seen. We have first seen how the nervous system is broadly classified. We did not deal much with the central, only the peripheral we took. So under peripheral, we first compared the somatic and the autonomic. Then we compared the sympathetic and parasympathetic. Then we compared the receptors among itself, like we compared alpha with beta. Then we compared alpha 1 with alpha 2. Then we compared beta 1 with beta 2. So the anatomy part was over. Then we saw a little bit about the physiology. Then biochemistry, about the tyrosine and the biochemical pathway. Then we just had an outline about the pharmacology also. So pharmacology should be very strong. Just that one slide will do. Just remember that one slide and everything you can pick up points from that one slide, I guess. So I hope this class was very useful for everyone. Thanks for the same. And our next class will be on Friday. So thank you.